Kelly. The next speaker is Dr. Sharanu Patil. He's a consultant anesthesiologist, Sparsh Hospital, Bangalore. He's got a fellowship in cardiac anesthesia from Narayan Rudralaya, and he's part of the team that operated Lakshmi, parasitic twins, for 27 hours. And his main interest is ultrasound-guided regional blocks.
Morning, everyone. And I thank organizers for inviting me for this talk. Yeah. I'm going to speak on axillary brachial plexus block, basically, using ultrasound assisted, and much less spoken about these mid-arm, also known as rescue blocks, mid-forearm rescue blocks. Coming to axillary block, it's already been spoken that now many people are started claiming that this brachial plexus can be considered as the spinal cord of the arm, as much as we do the lumbar subarachnoid plexus with its attended 100% success rate. And axillary block itself is a very superficial, most simplest, and it doesn't need any extraordinary skills, and it's very less risky in terms that it is quite far away from the important structures. When you consider the supraclavicular blocks, the chances of pneumothorax, all that is not seen in the axillary brachial plexus block. And also this is very ideal for day case surgeries, as it does not have any chances of blocking the phrenic nerve, and also there is less chances, almost no chances of pneumothorax, and is ideal for the surgeries on elbow, forearm, and hand surgeries. Now again, it has already been spoken, the axillary brachial plexus block anatomy. If you can see here, the radial, median and ulnar nerve are in the neurovascular compartment, whereas the musculocutaneous nerve, which lives higher up and does not get included in this neurovascular compartment, has to be blocked separately. And also the median cutaneous nerve of the arm, which also escapes this block. And you can also see on the right hand side here, the musculocutaneous, the axillary again, which is again given up very higher in the cords, and also the medial cutaneous nerve of the arm, which all these three which branch higher up does not get included when you do this axillary brachial plexus block. Now, cutaneous distribution of the arm, if you can see now, the axillary nerve here, which supplies higher up on the arm, medial side, which is being supplied by the medial brachial cutaneous, does not get included when you do the axillary block. Hence, it is best suited for your elbow surgeries and forearm and the hand surgeries. It is also important to know this cutaneous distribution, because once you are done with the block and you come back after 15-20 minutes, and you need to check whether it is a successful block or not. If there are any sparing, you can easily identify, as you know, the cutaneous distribution. The median nerve can be checked, this portion, the ulnar nerve can be checked here, and the medial the musculocutaneous can be checked at the lateral side of the forearm palmar aspect. And a radial nerve, it supplies the whole of the hand on the posterior surface and the forearm up to this portion. So if you know the cutaneous distribution thoroughly, and you come back and check which nerve is spared, later on you can try and give rescue blocks to cover these spared nerves. Now, just to go through some reviews, they have the loads of experiences behind them and what they have to say and have concluded. They say that this is the ultrasound guided blocks are operator dependent, and care must always be ensured to visualize the complete length of the needle along with the tip in order to avoid complications. Now, this Peter Marhofer, he says a safe and successful block requires appropriate imaging and detection of specific target nerves, and proficiency in tracking the needle advancement in real-time image, and also the fashion in which the local anesthetic is going to spread all around the nerve. Now again, high frequency probes are very important to have a very sharp images on the ultrasound, without which the image can be of poor quality and you may not be able to clearly identify the target nerves. So that becomes very important to use the ultrasound guided blocks. And a real-time needle positioning, minimizing damage to the neighboring vessels, increased success rate by improved distribution of lower volume of local anesthetics around the nerves. Also, it reduces time of onset because you deposit the local anesthetic very near to the target nerves, and also it reduces intraneural injection as you see it on the image in the real time. And he says that there is an assumption of a consistent anatomy with the performer when they use paresthesia technique and peripheral nerve stimulation. This is by Satapathy. He says the axillary approach remains the safest because, as I said, the risk of blockade of phrenic nerve nor the pneumothorax are less, and making it a very ideal option for day case surgeries. And he also says that multiple injections have greater success when compared to the single injections. Now, Thompson has examined the brachial plexus in many cadavers, also using dye studies on surgical patients, where he has found existence of many septae within the sheath, which precludes the local anesthetic by spreading, and hence he also advises to favors the multiple injection over single injections. Now, more importantly, the technique in which it is being done and the experience behind the person who is performing the blocks are important to have a successful block. And as we all know, 0.2 milliamps, even less, is a reliable indicator to detect intraneural injections. But when they have used ultrasound, at the same time, they've even noticed that stimulation currents of more than 0.2 but not more than 0.5 milliampules even could not rule out the intraneural injections. And there is some studies which have shown that in real-time 3-dimensional ultrasound assisted axillary blocks, arterial pulsation has got some influence on the spread of the drug when you give this axillary plexus block. And also, you will be able to reduce significantly the local anesthetic volume when you use these ultrasound. And this is by Steve. He has spoken a little beyond about the just blocking the nerves. What he says is that by possessing the skills to more effectively manage post-operative pain and its side effects, an anesthesiologist may attract more referrals from surgeons and patients. So just having the ability to execute the block is not enough. So that the additional commitment that defines successful region anesthesia in private practice. And he also says that this is a video of the axillary brachial plexus block. Now that's the probe position, high frequency probe, that's the inline needle, you can see. Now that's the axillary artery. You can see it's nicely pulsating, just superficial to the skin. That's a needle coming in. Since it's the inline plane, I mean, you can see the whole length of the needle along with the tip here. That's the median now. That's the median now. Now, as I inject some local anesthetic, I should be able to see some local anesthetic spreading, which looks more of hypoechoic, and that makes the background, when you inject, the background of hypoechoic makes the nerve, which is hyperechoic, to be seen very clearly. So that's your median now, just next to the axillary artery. This is the lateral, superficial, posterior, and medial. So now you can clearly see some local anesthetic all around the median. Now this is the humerus here down. Now I've just manipulated my needle just to go posterior to the axillary artery. Yeah. That's the radial nerve there. And so this is the advantage of having ultrasound, that you can manipulate your needle couple of more times so that you see the drug spreading all around the nerve clearly under direct vision. And now there is the ulnar now, little difficult to negotiate the needle, so I have done this using outline plane. I will go to the next slide. Just want to have a case scenario here. Just imagine an emergency case with a full stomach. We have inadequate history, nobody with the patient signed, incomplete evaluation, no time to optimize, and he comes in an odd hour, and we have very less helping hand. You can go and do these rescue blocks in case if you fail the main block. This is the median now at the forearm. Just in case you fail the main block at the axillary or supraclavicular, you have a very difficult patient, but you can still go ahead and give these rescue blocks at the median now. I'll just take one more minute. You can see in the cut section here the median now seen medially just next to the artery here in the groove which is made by the brachialis and triceps here. So this is the inline approach. Yeah. So this is the brachial artery. So just superficial and anterior is your median now here. That's the median now. You can see the whole length of the needle along with the needle tip just close to the median artery. So this is the radial. I've used out of plane approach here. That's your radial nerve just above the lateral epicondyle. That the response at 0.6 milliamps. And that is how it's going to look. This is the radial nerve here, just above the lateral epicondyle of the humerus. You can see the tip, you won't see the whole length because it's the out of plane approach. So that's the stimulation. And these are the few rescue blocks which are done under ultrasound at forearm levels. The median, it exactly is seen in front of the forearm, just below the flexor muscles. That's your median now. That's your radial bone. Yeah, that's the radial, the median now. You can see the whole length of the needle again. Drug spreading all around the nerve. Quite superficial block these are, you can see here. So I can manipulate as I can see the needle in real time. I can go above, below and inject so that the drug is seen spreading all around the nerve. And now as you move your probe little medial onto the forearm, you can see the ulnar nerve. Now I'm just going to move my probe from the middle of the forearm to more medial. We can see the ulnar nerve here, just above this ulnar bone. Yeah. Yes. So those are the rescue blocks at the forearm. Thank you.
Thank you, Dr. Patil. Dr. Bhatt, can you please come on stage? if you have any questions on auxiliary blocks, you can ask them quickly. And we'll have exactly 10-minute tea break after that.